Good. So let's look at elbow dislocations. Elbow dislocations is usually in adults. Kids tend to rather break their supracondylar bones than dislocate, though you do see it. And to remember that elbow dislocations, actually, I've often wondered, how can you dislocate without breaking a bone? But actually, imagine how much ligaments and things need to be injured to be able to dislocate. So that's why we need to immobilize afterwards for 2 weeks and refer to physiotherapy. But quite simply, to reduce it is to get and I'm going to stop my screen share here and just quickly attempt again to show you. Get the arm in the anatomical position. And anatomical, remember, is basically with your hands open to the front. So the radius and the ulna is running parallel. If you try and reduce it in basically in pronation, you lock the bones and you're not going to be able to get a good pull right out of the and reduce. So getting into a neutral position, get somebody on the upper arm, set your body, and then good pull while you push on the olecranon and you bring it over, and it usually reduces actually quite easily. But I think the most common mistake we make is not getting into a correct into the anatomical correct position there. So that's reduction on elbows. The post-op is, or post-reduction is important. Put them just in a sling for 2 weeks. They don't need a back slap, but a lot of people prefer back slap. I like to use a sling because I think that little bit of movement on the elbow is actually healthy. An elbow just becomes stiff so quickly. So 2 weeks, and then the physiotherapist can start with mobilization. And remember, they do active mobs, not passive, because you myositis ossificans, problems like that. But not to immobilize it more than 2 weeks, I think, is quite important. Moving to kids in supracondylar fractures. This is the most common fracture in kids. So I think the most common question we ask ourselves when we sit in casualty in our small hospitals is, do we have to reduce this one or not? And I think this picture on the right shows you is just this simple rule that I use for myself to decide if I'm going to reduce it or not. Let me just quickly move to the next picture. Gartland fractures. So this is how we grade supracondylar fractures. Gartland 1, 2, and 3. Gartland 1 is basically it's broken. You quite often struggle to see this on the X-ray. You get the fat pad, anterior, posterior, maybe. Very insensitive way of looking at it. But then the Gartland 2, you start getting displacement of the anterior wall, and the space starting opening up, and it's starting looking not good. And then the Gartland 3, heaven forbids, then it's totally displaced. And then you get variations on that where there's a Y fractures, where it's a destroyed elbow. We almost always, anything more than a Gartland 1, we will do a reduction, because by just reducing it back into its space, correct position, you stop pain, swelling, blood flow, nervy injuries, all those things get avoided. So I think understand the Gartland fractures, then can quickly look at an X-ray, decide what you need to do. So the picture here I've got on the right is a Gartland 1, actually. And the way I decide I'm not going to reduce this patient, if you draw the red line on the anterior surface down the humerus, it passes through the growth plate on the distal humerus. And as long as it passes through that growth plate, that line you draw, you can probably accept it and treat it conservatively. The conservative treatment, yet again, is a back slap. Kids swell a lot on elbows, and if you do a circular pop, you're probably going to run into trouble there. So back slap for a week, and then you can follow up, take off the back slap, do a circular pop above elbow, 3 to 4 weeks, at the most 4 weeks, and then they start with active mobilizations afterward. Remember to always check the neurovascular, whether it's intact, and document it pre and post reduction, so that you're just medically legally covered there. Moving on. Right. So the reduction technique is much the same as an elbow dislocation in an adult. So you're going to get a big strong body on the upper arm, and you're going to pull with a and give a good long pull like you do in the Colles fracture. You first disimpact with the arm in a straight position, and then as you bring him over, you can also have a hand on the olecranon, and then just help that break it into position, back into position. Usually there's a nice crunch to indicate that something is moving. And then we take the post-op, and then you back slap it. The flexion actually keeps that distal segment then in place, not the POP. So the POP and how tightly it fits is not as important as just the fact that the arm can't be extended. And if we can do this effectively, we're going to actually save our level 2, level 3 hospitals a lot of work, because I think people just send these patients and it's actually such easy reductions. Moving on to humerus fractures. You can accept up to 1 centimeter displacement between the two bones, and you can accept up to 45 degrees angulation, which is so much. It just tells you what the motto of a humerus fracture is: if the two ends is in the same room, it will heal. And I mean, this just demonstrates it's really a fracture that usually do very well. But to understand the principle of how we treat it is, we want the two ends to be as close together as possible, as well aligned as possible. And we know it's going to be impossible to immobilize it like we can a forearm or a lower leg or an ankle or something, because it's an upper arm and it's difficult. You know, you need to wash and the arm is moving. So the best we can do is a U-slab. And what we basically do with a U-slab is we first put the hand in a sling around the neck, and then we put on the U-slab. Well, that's the way I do it anyway. And by doing that, we get the actually gravity and time over time to reduce that humerus. If it's a little bit, usually day one, we start with a bit of angulation, and then over time, as gravity relaxes the muscles, the angulation corrects itself, and it can heal nicely. On the right, I've got a picture of a Sarmiento splint. I understand it's a doctor in Argentina, somebody that described it, but this is actually the ideal form of immobilization of a humerus fracture, a splint like that. And if you look at that, that's basically what we're doing with a back slab with POP or U-slab. And I think it's pretty effective, the treatment we use there. It takes quite a while for the humerus to heal in older patients. Remember, healing is slower in old patients that smokes and is on steroids, worst case scenario. So those three, then you're going to have slow healing, and it's probably going to go up to 12 weeks. So keep that in mind. Compared to kids that's healthy and playing around, then they heal in 4 weeks. A newborn with a humerus fracture probably heals within a couple of days. So yeah, the age is important if you want to work out the healing time. Moving on to shoulder dislocation. So this is a classical, the top picture is a classic posture. The patient is walking in with one shoulder drooping and the arm being held and looking very sorry for himself. And then if you examine the patient, taking the shirt off, you can feel that empty space below the coracoid process. And it's just a classic clinical diagnosis. When I worked at Zithulele, there was a time, I think we ran 3 months without X-ray machine, and we basically had to develop X-ray eyes. This, you just realize you can, some fractures or dislocations, you can really pick up quite accurately on examination. The reason we would prefer to do the X-ray first, obviously, is you want to see if it's not a fracture dislocation, because sometimes we would treat them differently. But in principle, reduction, the earlier the better, is great. So shoulder dislocation, clinical picture. Moving on to the reduction techniques, there's 4 described techniques and 500 versions of in between of those. So you can use any of these techniques. I've got the pictures on the right. The Kochler's method is my favorite. If you use the Kochler method with, which basically you just arm and abduction, bring in the elbow, roll it over. It's as easy as that. big rugby players, if you give good analgesia, obviously reduces easily. And the cochless method, I recently had a doctor sending me pictures asking what's wrong with his shoulder, and then I just had to tell him that's a dislocation. I suggest use the cochlear method, and I checked. There's very nice picture, demonstration of the cochlear method on YouTube. So just YouTube it, look and try it. It works. It's my favorite technique. The one we know probably best is a Hippocratic method, where you put your foot into the axilla and pull. Yet again, it's very effective, but it's a very big hammer to use, and there can be side effects, damage to the nerves in the axilla. Yeah, it's an option. You can use it. Stimson's, so that's that one. Stimson's is another form of torture, in my opinion. You can use it, and the picture they demonstrates it very well. But I think it's terrible telling a patient this is terribly painful, but lie like this for an hour or two, and then it will reduce by itself. So I would suggest not using that one. Milch's method is, in a way, what you're doing with the Hippocratic method, you're doing with your fingers and your thumbs, just manipulating it back. But to remember, there's variations of and other tricks you can use that you can learn from older doctors. I've got one where I wrap and put the blanket in the axilla, pulled by one person, while I pull on the arm in another direction, which is actually the Hippocratic method using blankets. And then there's also, in patients that regularly dislocate their shoulders, you can quite often, just by talking to them and slowly putting your hand in the axilla and pushing on the head of the humerus, while you just slightly, shaking that arm left, right, they pop back by themselves quite often. I usually try that, and without any pain. So lots of techniques described. I can really just remember good analgesia. If you try and do this under 25 milligrams of pethidine, the muscles are going to be so tight, you're not going to be able to reduce it, no matter how big the patient or not. So good sedation, and you'll get it back. Reminder, you get the 99.9% of shoulder dislocations is anterior. And I remember it, if you think of how the American football players throw the ball and then they get tackled from behind, that's a classic way to dislocate anterior. And that's by far the most common way we dislocate shoulders. Posterior dislocation is rare, and we pick it up on an X-ray, and very nicely demonstrated is the light bulb sign. You might remember it from varsity. The humeral head looks like a light bulb, quite nice and symmetrical, and it's sitting lateral to the glenoid bone. If you think of the anterior, usually the humeral head is sitting way more to the medially. So remember about the posterior dislocation. And quite frankly, if you see this, take a picture, because you're probably not going to see it again, and then just Google how to reduce it. It's very easy. Google helps a lot in desperate times. Clavicle fractures is one of those things I've worked with in level 2 hospitals, where the orthopods say, I don't want to talk about clavicles, I don't want to operate, I don't want to know, just manage it conservatively. And yet again, 99% of cases, we will treat it conservatively. I think important to know the cases where we need to discuss this. Most definitely, if it's an open fracture, talk to your friendly orthopod. But also when the skin is tenting, if the skin is standing like this because there's a fragment pushing from below, it's going to become necrotic, the skin, and you're going to end up with an open fracture. So when if the fracture is tenting, compound fractures, and in theory distal third fractures, we will refer. Depending on orthopedic departments, they will manage it or not. Mostly where I've worked, they treat them all conservatively. Important to know, even if those, like in the picture we've got here on the slide, even with the ends not touching, this is going to heal. The clavicle heals very well, and middle third fractures do extremely well. Actually, the preferred treatment is conservative. You've got risk. If you open it and you orify, yes, you've got quicker back to the sport you play or whatever, but you've got the risk of non-union and infection, big risk. So I think in government service, in low resource setting, deep rural hospitals, 99% of this we're going to treat conservatively. That ends the upper limb part. The lower limb, I think there's a little bit less